Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today, we've synthesized a really crucial stack of resources, the latest CIRSE standards of practice and the DRAGON trial findings. The goal here is to give you an immediate, actionable update on liver regeneration therapies.
Yeah, and this deep dive, it's really built for one mission, making sure the procedures you perform, we're talking PVE, are truly maximizing that future liver remnant, the FLR.
Right, FLR. We'll be saying that a lot.
We will. And PVE, portal vein embolization. These are, the key concepts.
And the why behind all of this hasn't changed. It's about minimizing the risk of post-hepatectomy liver failure, HLF.
Still the big killer.
It's still the major cause of morbidity and mortality after these huge resections.
Exactly. I mean, our goal is to get that patient to the OR safely. And not just safely, but with enough functional, healthy liver to actually thrive after the surgery.
We're basically mitigating the surgeon's risk before they even pick up a scalpel.
That's the perfect way to put it.
Okay, so let's start with the foundation. PVE is still the established, first-line standard of care.
It is. The CIRSE standard of practice guidelines reaffirms that it's safe, it's effective for FLR hypertrophy.
And you're typically looking at resection 3 to 5 weeks after the procedure, but there's a huge drawback here, isn't there?
And it's what's driven this whole field forward. The data is, it's pretty sobering. 15 to 20% of patients who get a PVE, they never make it to the planned hepatectomy.
15 to 20%. That is a stunning number.
It's a stunning failure rate, especially with oncologic urgency.
I mean, think about what that means for the patient. They've gone through the whole workup, the PVE, and then nothing.
Right. Precious time is lost. Either their tumor just kept growing while they waited for the liver to get big enough,
or the hypertrophy just wasn't good enough.
Exactly. It was insufficient.
Yeah.
So you're in this race against the tumor's biology, and, PVE alone often just isn't fast enough.
And that's what's pushed us toward these faster, more robust techniques.
Which brings us to the combined approaches.
DVE, double vein embolization, and LVD, liver venous deprivation.
Right. And we should be clear, we're not talking about doing things sequentially. This is a single session.
Okay, so what's the core difference?
You're doing a selective embolization of both the portal branches and the ipsilateral hepatic vein branches. That's the key addition. Blocking the outflow from the part of the liver you're going to resect.
Blocking the outflow. I mean, that sounds a little counterintuitive. Why does blocking the primary drainage make the whole process faster?
It all comes back to that 15 to 20% failure rate. After PDE, the liver is smart. It tries to normalize flow by growing these portal vein collaterals, and they connect the future remnant back to the embolized part. These collaterals, they effectively steal blood flow away from the FLR.
So they dilute the whole effect.
They compromise the hypertrophy, they wash out all those important hepatotrophic factors that you need for regeneration.
So the collaterals are the enemy.
They're the enemy of hypertrophy. By adding hepatic vein embolization, or HVE, you block the outflow. The pressure builds up on the side that's coming out, and it prevents those collaterals from ever forming.
And that creates a much stronger stimulus.
A much stronger, faster stimulus, more robust FLR hypertrophy, and hopefully much lower rates of post-hepatectomy liver failure, PHLF.
That makes perfect sense. Okay, let's dig into the technical side, because this is where your choices as an IR really dictate the outcome. Let's start with standard PVE, the embolic agent.
The clear first-line choice, hands down, is NBCA.
The glue.
The glue. Multiple studies in the CIRSE summary show it's just superior to older things like PVA particles or coils.
Yeah.
You get greater and faster FLR hypertrophy.
Why, though? Why is glue better than particles?
It's about permanence and penetration. NBCA gives you a total immediate occlusion, a complete cast of the portal tree. Particles can migrate, they can recanalize.
So you get a more sustained regenerative signal.
A much stronger, more sustained signal, yeah.
Okay, but when you're injecting something that powerful and permanent, what's the critical precaution you have to take?
You have to use microcatheters. You just have to. NBCA sets up fast. If you're using a standard catheter, the risk of it refluxing, of non-target embolization to the FLR, the very thing you're trying to protect, it's just unacceptable.
Okay, so moving to the combined procedures, DVE and LVT. The HVE part, access can be tricky, right?
It can be. The transhepatic route is probably the most common, especially if you're already going that way for the portal vein.
But there are other options.
Absolutely. Transjugular, transfemoral, they're both viable. It really depends on operator comfort and the patient's specific anatomy.
And what about sequencing? If you're doing both in one sitting, portal vein first or hepatic vein first?
The consensus, especially if you're using NBCA, is PVE first.
Why is that?
It's all about pressure dynamics. If you block the hepatic vein outflow first, the pressure in that segment can shoot up. And if you then inject glue into the portal side,
It could reflux.
it can drive the glue backwards right into the contralateral non-target side.
Okay, so for the HVE occlusion itself, we're talking about vascular plugs, mostly.
Mostly plugs, yes. And the guidelines are very specific here. You need to oversize the plug by a good margin, around 40%, to make sure it doesn't migrate.
And placement is key too.
Placement is critical. You want it approximately about 15 millimeters from the IVC junction. This gives the surgeon a clean margin to work with later. You don't want your plug getting in their way.
Now, can you clarify the difference between DVE and LVD? It's subtle but important.
It is. So DVE, double vein embolization, is generally mechanical. Plugs, maybe some coils, to block the main hepatic vein.
Okay.
LVD, liver venous deprivation, takes it a step further. It uses the plugs plus NBCA glue to go after the smaller, more distal venous branches and collaterals.
So LVD is more aggressive, more complete venous blockage.
Exactly. In theory, it could lead to even faster, more uniform hypertrophy, but
There's always a but.
there's a unique risk. You're injecting glue into the venous system, so there's a potential path for non-target embolization to the lungs. It's a risk to weigh, though it's low in experienced hands.
And what about segment 4? It's always a challenge. How important is it to get that?
It's increasingly seen as a key part of a complete right liver exclusion. It's tricky, you need advanced tools like angio-CT or cone beam for 3D road mapping.
But it's worth the effort.
For experienced operators, it's safe, and it definitely adds to your FLR hypertrophy. Sometimes, failing to get segment 4 is the difference between making volume and not making volume.
Okay, procedure's done. Now we wait. Let's talk assessment. We've got CT or MRI for volume. We're calculating the FLR-TLV ratio, the future liver remnant, to total liver volume ratio. But the thresholds are not one-size-fits-all, are they?
Absolutely not. This stratification is non-negotiable. For a totally normal liver, an FLR-TLV of 20% might be okay.
But that's almost never the patient we're seeing.
It's almost never the patient. If they've had chemo, that threshold jumps to at least 30%.
And for the highest risk patients.
Cirrhotic cholestatic livers, you need a bare minimum of 40%. You have to start your planning with that liver health assessment.
But just hitting a static number, that final ratio, that's not the whole story anymore. This brings us to a more dynamic assessment, the kinetic growth rate, KGR.
Yes, KGR is so important. It measures the vigor of the regeneration. It's the degree of hypertrophy you get divided by the number of weeks you waited.
So it's a speed measurement.
It's speed, and it tells you about the health of the response. The data is compelling. A KGR of 2% per week or more is directly correlated with an absence of post-hepatectomy liver failure. Lower mortality.
So if you see a low KGR.
It's a massive red flag. That liver might not be ready no matter what the final volume number says.
Okay, so KGR is speed. What about quality? The actual functional reserve of that new tissue.
This is the next frontier. We're moving towards advocating for routine functional assessment, especially in these high-risk cases.
Things like mebrofinin scintigraphy.
Mebrofinin, or GDEOB DTPA enhanced MRI. These tools estimate hepatocyte function directly, because we know volume gain does not always equal functional gain.
Right, and this whole framework really sets the stage for the DRAGON collaborative trials. Let's start with DRAGON 0, the retrospective survival data. This one really changed things.
It did. DRAGON 0 compared PVE alone versus PVE plus HVE, and the results were, well, they were stark.
They were. The headline number for IRs has to be resectability. PVE, HVE got a 92% resection rate.
92%. Compare that to 68% for PVE alone. That is a monumental jump in getting patients to a potentially curative surgery.
And that jump translated directly to long-term survival, didn't it?
Directly. In the PVE-HVE group, the median overall survival wasn't even reached at 36 months. For the PVE alone group, it was just 20 months.
Wow. That's a huge difference. Was the procedure itself the driver?
The analysis was clear. PVE-HVE was an independent predictor of survival. The hazard ratio was incredibly favorable, around 0.5. The takeaway is undeniable. Combined embolization gets more patients to surgery, and that means they live longer.
Okay, now let's go to the prospective data, Dragon 1. This was about safety and speed.
Right, mostly in colorectal liver mets patients, and it confirmed the safety profile. The primary outcome was 0% embolization-related 90-day mortality.
So the procedure itself is exceptionally safe.
When done correctly, yes, very safe.
And what about the speed? Did that hypothesis hold up?
The speed was remarkable. They measured the KGR in the first week, and it was 8.3% per week.
8.3. That's more than 4 times that minimum safety threshold we just talked about.
Exactly. This hyper-rapid growth is what allowed 90% of those patients to get to their resection.
So, high safety, extremely high resectability, better long-term survival. This sounds like a home run for combined embolization. But there's always a but, isn't there? What's the paradox in the Dragon 1 data that we need to wrestle with?
We do. We need to look past our procedure and at the final outcome. Despite that 90% resection rate, and despite hitting all the accepted volume cutoffs, the 90-day post-resection mortality was still 8%.
8%? That's too high. After all that work, what was causing those deaths?
Almost entirely post-hepatectomy liver failure. Grade B or C post-hepatectomy liver failure occurred in 22% of all the patients who got resected.
22%.
This is a huge red flag about our current assessment protocols.
Okay, so this is the key takeaway. The fact that so many patients develop significant post-hepatectomy liver failure suggests that relying only on a volume number like that 30% FLR for chemo-damaged livers, it might be too liberal.
It might be dangerously liberal. Volume alone is not enough to guarantee a safe resection.
It's not the whole picture.
Not at all. I mean, when you push the growth that fast, are you sacrificing quality for quantity? You might get a big, beautiful liver on the scan, but if the hepatocytes themselves are still functionally compromised, the patient is still going to fail post-op.
So the path forward isn't just about doing more DVE or LVD. It's about demanding functional data before that patient goes to the OR.
Precisely. We have to push for objective functional assessment like mebufotenin, and we have to track that KGR. These need to be co-requisites for surgery, especially in these high-risk, accelerated patients.
It's an incredible synthesis. So to wrap it all up for you, combine techniques like DVE and LVD work. They accelerate growth, they get more patients to resection over 90%, and they improve long-term survival. But the finish line isn't the volume on the CT, it's the functional capacity of that FLR.
Yes. And here is a final provocative thought. Given that Dragon 1 saw a significant post-hepatectomy liver failure rate even when patients hit their volume targets, how quickly will our practice be forced to move beyond purely anatomical goals and instead rely on dynamic functional markers like mebufotenin uptake or KGR to prove a liver is truly ready before the surgeon decides to cut?
That is the challenge for the future of liver surgery.
That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.